I will now be pausing the recording.
We are go. Good afternoon, everyone. This is the November 14th meeting of the Oregon Health Authority's Health Evidence Review Commission. We will thank you for being here this afternoon for this very important work. With that, Jessica, do you want to go ahead and call roll?
I sure can. One moment.
Go ahead whenever you're ready.
One moment. Technical difficulties. I'll have it up in just a second.
No worries.
I can go ahead. I've got it here. So Devin Kinsager, our chair, is not able to attend today. Adrian Irwin.
Here.
Mark Buchholz, I believe, is on the phone. Jessica, actually, can you make sure he's able to unmute? He's on the phone. And Mike Collins.
I only see one phone number, so I'll just allow them. I'll promote them. Allow them to talk and see what happens.
Okay, and he may need to unmute using *6. Mike, if you're able to hear. Mark. Okay, while he works at that, we'll go on. Mike Collins.
Present.
Stacy Geisler.
Here.
Ben Hoffman. I believe he'll be joining later. Max Kaiser.
Here.
Lisa Cruzes. I believe she is on an airplane. Linnea Lindsay.
Present.
And Mark, is that you on the phone?
I'm hearing
Okay.
some background music.
Yeah, I think that's coming through the phone, so it must not be Mark. So why don't you go ahead and demote that person to participant status or mute them. Okay, sorry. Dr. Lyon let me know he will not be able to attend. Chris Pinzone also cannot attend. Katie Shavel.
Present.
And Leslie Sutton.
Here.
Wonderful, great to have you here today.
That gives us form.
I believe so, yes. Let's go ahead and, do you want to do the presentation? Oh, go ahead.
So just as a friendly reminder, at the beginning of every meeting, we are asking for HERC commissioners to declare any conflicts of interest related to items on the agenda. So if you have any conflicts of interest, please take this moment to disclose them to the commission. Okay, hearing none. So I will go ahead and turn it over to Jason, who will go through our orientation statements and slides before we begin today's work.
All right, I'm just bringing those up on the screen now. So as always, our goal here in the Oregon Health Authority is to eliminate health inequities by our 2030 goal. So we'll work taking steps towards that today to get advances. We're going to be making coverage decisions that will affect the over 1 million members of the Oregon Health Plan, as well as their families, caregivers, and providers. However, these decisions will be policy decisions. They will not, we will not be reviewing any individual cases or making decisions about individual care. The decisions are about covered benefits, and medical necessity for Oregon Health Plan. We'll also be hearing some public comment. Proposals you may have seen in the meeting materials are not final until they're approved by this body. They will be implemented at later dates, and those are specified in the meeting materials and will be discussed here. Our general considerations include the assessment of the balance of benefits and harms based on the best available evidence. We also consider patient values and preferences, good stewardship of public resources, and the nature of Oregon's healthcare delivery system. If you're attending online, if you're a member, please be on camera as much as possible. If you need to step away, if you could please chat Jessica so she can keep track of quorum. So we have a good record of that. And Jessica, are you recording?
I am. I resumed the recording.
Wonderful. And members who are online, if you can put your votes in the chat, it's a little hard to keep track of verbal votes, both in the room and online. So if you could use the chat function, that would be much appreciated. And then speak up or raise your hand rather than putting things in the chat, because we want everything to be a part of the discussion so that people don't have to be focusing any more places than they already have to follow our discussion. If you are offering verbal testimony, I believe we have one person zooming in today. Make sure your Zoom name matches the registration name. Just right click on your name and change it to that. Other participants can use the QA feature. Everywhere it says Daphne Peck. Unfortunately, Daphne is on leave right now. We hope to have her back at the next meeting, but reference Jessica Malmstrom. She's providing our admin support today. That said, we won't be able to answer questions during the meeting, so best to keep the comments to logistical questions. The chat and Q&A do become part of the public record, and this meeting is recorded and will be posted online. Go ahead. Is there anything else? Is there another slide in this? No. Okay, then we can do staff report.
So did I see Dr. Mark? I saw a camera go in and out. Have you joined us, Mark?
Yes, I'm here. Can you hear me?
Yes,
Perfect,
Suzanne.
thank you. We'll record that for the minutes. Thank you so much for confirming.
And we can see your view through your dash cam. You might want to turn off your camera.
Oh, I'm not driving. How's that?
Oh, that's better. Oh, you're riding. Good. That's
Perfect.
safer.
Awesome.
Yeah.
We will let the minutes note that you are now here in attendance. Okay, go
Sa-
ahead.
Sounds good. I'll turn off my video, but I'm
Okay.
here.
All right, staff report. So a couple of items on the staff report. First of all, we'll have an update on the benefit update project later in the meeting, so stay tuned for that. We're also going to be making some changes to our meeting materials, our meeting packets. We're currently publishing separate packets for the Value-Based Benefits Subcommittee, which met this morning, and the full commission. Much of the content is the same. It's just the Value-Based Benefits Committee version includes all of the medical studies, or at least the abstracts. Your packet today includes links to those abstracts, which you can click on and review the meeting materials. And those will take you to the abstracts, or in some cases, the full text of the articles. The exception to that is proprietary information that we are not at liberty to publish. And so those will continue to be available to members only. So that is a change. It shouldn't affect this group as much as it will the other group. But for today's discussion, we're going to call out page numbers, and those page numbers will be from the packet, the public packet on the public webpage for the Value-Based Benefits Subcommittee. If you're using that to follow along, please make sure you're using that publicly available. I think it has 500 to 600 pages instead of 2,400 pages. That'll just make it easier to keep track of where we are. Next, I'll give an update on Senate Bill 1508. Again, that passed last spring, and that was related to quality adjusted life years and other similar measures. And it also made some other changes to our process. But first of all, we met and held a listening session regarding the formation of a disabilities health advisory panel. I briefed you on that, and Liz briefed you on that at the last meeting. We don't really have any updates, except that we continue to be working on that. Hoping to be able to pull that together in the first quarter of next year. Secondly, we are working on a history of all the uses and appearances in HERC meeting materials and our predecessor commission, the Health Services Commission, since 2006, where we have referenced quality adjusted life years. We are working through that, and that will become part of the biennial report that will be published in the spring of next year. And so that will be put up for comment, and that will be brought before you to look at, and we may have some agenda items resulting from that. We also have a new process where we search our current meeting materials for quality adjusted life years. And if any of the articles referenced in the meeting materials contain those, my colleague Liz Walker will be reviewing those to ensure that our recommendations do not rely on those measures, but are based on other factors. And she's checking that and documenting that she has completed that review, and that happened for this packet of this meeting's materials. Finally, we will be hiring a new evidence contractor, hoping to have that in place by early next year to supplement the great work that the Center for Evidence-Based Policy has been performing for many, many years. And that is required by the statute that we have multiple vendors. Two more things. One is that we are still hiring a medical director to help Ariel out. If you know somebody who may be interested, please put us in touch. And then also just to acknowledge, we will be headed in February into legislative session, and work is ramping up to that. And if you have questions related to that, or if you have something you should know, please be in touch. We do expect at a minimum note to be a bill related to the benefit update project, since that will change how our work looks in statute. Any questions or comments on any of that from members? Okay, let's go on.
Okay, thank you so much. So the next item on our agenda is public comment for items not onto the agenda. So before as a quick orientation, right now we have one person online as well as two individuals in person that want to provide comments on the same topic. So we were going to take all three of those comments. In addition to that, we also have someone from Oregon Health Authority that's going to kind of provide some remarks as well, and then we will open the discussion up to the commissioners. So the first item, or the first individual is Mr. Paul Turdal. Are you here, Jessica? Is he here?
I believe so. Let me give him permission to talk.
Before we do that for a moment, Jason, are you reading the statement with Jessica?
I can read it if that is helpful.
Yeah, go ahead and read
Go
that,
ahead.
and then take him off mute, and do his testimony. We have people in the room as well.
So, and here, Mr. Turdal, let me find you. All right. Before you start speaking, Mr. Turdal, I want to read this preamble. This next topic may be sensitive, a sensitive discussion for some. As a reminder, HERC is a policy-making body and cannot make decisions about coverage or care for individuals. Any policy changes resulting from today's discussion will go into effect at a future date. This discussion may be intensely personal for some, yet in this forum, we tend to discuss subjects in terms that can seem clinical and impersonal. Not every person's experience will fit into the picture that the clinical evidence shows. Please be aware that our commission's business is to make the best possible decisions for the general population using the HERC's methodology and process to determine the importance of services. Based on the number of people signed up today to testify, we will allow up to 3 minutes for each person. A progress bar will show how much time is remaining. After your allotted time ends, please remain in the meeting for a few moments in case members have any follow-up questions for you. Please begin your testimony by stating your name and any conflicts of interest you have regarding this topic. The Health Evidence Review Commission welcomes and appreciates public testimony. We understand it as an important consideration for our work, and we will listen with attention and respect. Although members may not discuss this comment right now, staff and leadership will discuss it prior to the next meeting. As a reminder, this commission does not decide whether particular services should be covered for an individual. Patients based on their individual circumstances, staff can help connect OHP members with helpful resources. Each speaker is given 3 minutes to help keep us on time. We will start a timer for each commenter. Please conclude your presentation when the timer ends. And I see Liz has the timer up. So I believe Mr. Turdal, you have the floor.
Great. Can you hear me okay?
Yes, we
Yes,
can.
we can.
Can hear you.
Great, thank you. So my name is Paul Turdahl. I'm a volunteer health consumer advocate for individuals with autism and other disabilities and the father of 2 children on OHP. I do not have any conflicts of interest to disclose. Um, yeah, I'm speaking to you today really to follow up and reiterate previous testimony that I have given over the last few months to request a formal medical technology assessment of gender affirming treatment and development of an evidence-based guideline. I would also ask you to withdraw your endorsement of WPATH Standards of Care version 8. WPATH 8 is the accepted standard of care for coverage under House Bill 2002. As I have testified before, in 2023, last year, HERC staff commissioned a rapid review of gender-affirming medical interventions from the OHSU Center for Evidence-Based Policy, with support from the Medicaid Evidence-Based Decisions Project. Their plan was to present the report to you in your August 2023 meeting. That report, the draft report, raised significant concerns with the quality and strength of evidence for gender-affirming medical interventions, especially for children and adolescents. The center wrote that, quote, "We did not identify any SRs with extractable data on gender-affirming medical interventions among adolescents and youth. Given that paucity of data, we summarize the findings from a single identified SR and so forth." So you can read the full quote. Faced with that paucity of data, to use the center's words, on the passage of House Bill 2002, the staff canceled the contract, abandoned the review, and withheld that draft report from publication. Regrettably, other researchers have also been withholding data relating to the efficacy of gender-affirming treatment. In my written comments, I cited several examples. There was a New York Times article just a few weeks ago about Dr. Olson Kennedy, who was doing lengthy research finding that the puberty blockers and pro-sex hormones did not actually improve mental health in children with gender distress, and she withheld that specifically because she was concerned that it would be used for political purposes. Similarly, anyway, I'll wrap up because of time. But what I really want to emphasize is families and individuals experiencing gender dysphoria really need HERC to publish its evaluation of evidence regarding the efficacy and safety of gender-affirming care so they can make the most informed decision possible about treatment decisions. HERC's decision not to publish the report it commissioned, which contains precisely that information, causes active, irreparable, ongoing harm to these individuals by depriving them of the information that they desperately need. Thank you.
Thank you, Mr. Turdahl. As a friendly just reminder to the commission, we're going to take all 3 public comments before commissioners will have an opportunity to engage with anybody providing comments. So with that, I'm going to have Dr. Karen Silva and Mr. Jess Guerrero come forward and sit at the table. And just, sorry, that way they can see. Yeah, that way the people in the video, right, those 2 chairs, sorry. That way people on video can see. And then in addition to that, can we just kind of formally for the minutes recognize that Chris Bizon has joined us as well for this afternoon. Welcome, Chris.
Before you just state your name and your organization representing in conflict of interest.
Going first. My name is Karen Selva. I'm from Randall Children's Hospital, and my only conflict of interest is that I provide gender-affirming care. I'm a pediatric endocrinologist serving as the Randall Children's Hospital Senior Medical Director of Subspecialty Medicine. I also am the Medical Director of the RCH Gender Care Center. I've been providing specialized care to transgender youth since 2010. In fact, I previously stood before this committee advocating for coverage of medical care for gender diverse youth in 2014, proudly seeing this coverage come to fruition in 2015. I'm here today representing the physician's perspective, having worked closely with fellow pediatric endocrinologist Kara Connolly, OHSU Doernbecher's Gender Care Clinic Medical Director, to construct these comments. Over the past 3 decades, numerous peer-reviewed research papers in well-respected academic journals demonstrate the positive impact of medical care for gender diverse youth on mental health and well-being. Most recently, JAMA published a study last month that demonstrates a large sample of gender diverse youth reporting high levels of satisfaction and low levels of regret with puberty blockers and hormone treatment. Oppositely, the Cass Review, published in April of 2024, has had negative implications on the provision of medical care for transgender youth. Hilary Cass, a general pediatrician, was commissioned by the UK's National Health Service to produce a review examining the failure to provide timely, competent, and high-quality care to transgender youth in the UK. She summarizes the review as exhibiting weak evidence in support of gender-affirming care. However, many methodological flaws have been identified in the data analysis and the systemic reviews conducted, which have called into question the validity of this report. Unfortunately, in the short time since its release, the Cass Review has been used to justify restrictions on healthcare for transgender youth. However, nowhere in the 388-page document does this review recommend a ban against medical care for such patients. We want to emphasize that the Cass Review makes statements that are consistent with models of care described in the guidelines developed by WPATH and the Endocrine Society. For instance, both agree that medical care is appropriate for some transgender youth and should be provided in a holistic, comprehensive, and individualized manner, which is consistent with the approach in all of Oregon's pediatric gender clinic. I'd like to remind you that not all transgender youth desire or seek out medical therapy, and thus use the word some. And both agree that in developing guidelines that provide recommendations on clinical care, panels of experts, such as yourselves, consider the evidence of treatment's efficacy, along with risks, benefits, family values, and resources. Gender care is nuanced. I can't say that enough. This is precisely why evidence quality is not synonymous with clinical recommendation, a fact that is confused in the interpretation of the Cass report. It's scary.
Sorry about that.
It's okay. You can go ahead and
I
finish.
have
You
one last paragraph.
You can go ahead and finish.
Okay, lastly, we know already that the rules preventing access to gender-affirming care lead to significant harm, increasing the risk of suicidal ideation and self-harm behavior. They also undermine the supportive health care that all youth deserve and that Oregon has taken leadership in preserving. We presently see this demonstrated in surges in crisis line calls in states with bans on transgender care. We urge you to recognize the needs of transgender and gender diverse youth by supporting policies that uphold their access to medically necessary care.
My name is Jessica Guerrero. I'm a pediatric social worker at OHSU's Dornbecker Gender Clinic, and no conflicts other than that I provide gender affirming care for folks. Thanks so much for having me as a board What's that?
I think you just speak up.
Speak up, yeah, sure. I had laryngitis last week, so I'll try
No
my
worries.
best. No, you're great.
Over.
As a board certified clinical social work associate, I've worked with gender diverse youth and their families since 2011, offering comprehensive assessments, individual and family therapy, resource navigation, support for gender identity and transition goal exploration, and participation as a mental health provider on an interdisciplinary team. I'm here because it's come to the attention of the gender affirming care provider community that misinformation about WPATH is being brought to this committee consistently, and we thought it would be best to hear directly from the individuals providing this care. My clinical practice has been informed by the guidance offered in the WPATH standards versions 6, 7, and 8, and has evolved alongside of the revisions and updated recommendations in each version. Remaining up to date on the most recent WPATH standards allows me to ensure that my practice aligns with the most updated literature and evidence and is responsive to community care needs identified. In partnership with our clinical psychologists, we developed and continue to evaluate and improve the mental health assessment and treatment model of our clinic. This model emphasizes that any treatment decisions are made in collaboration with the patient, their family, outside mental health professionals, and experienced medical providers. Because the WPATH standards are our foundation, our clinical model is in alignment with other gender centers statewide, nationally, and internationally. The WPATH standards describe medical and mental health practices that holistically support gender diverse youth. These guidelines are based on robust clinical evidence done over decades, highlighting the mental and physical health benefits that gender affirming treatment can provide, and we've offered some supplemental materials to support that. And version 8 represents the current international best practice guidelines and utilizes a literature review of the safety, risks, benefits, and outcomes for all treatment decisions, including the decision not to pursue medical interventions. Version 8 was developed by a group of international medical, policy, and mental health professionals of varying backgrounds, including individuals of trans experience. The implementation of the standards first required a period of community comment and a certification of at least 75% of the membership. Version 8 also specifically addresses care for adolescents as a separate and unique set of treatment considerations, compared to earlier versions that conflated the treatment needs of adolescents with the social needs of younger youth. Version 8 explicitly recognizes that medical treatment for gender dysphoria is only appropriate for some adolescents, and this is determined by an individual's goals and identity exploration, parental input and support, mental health evaluation, and medical provider input. The WPATH guidelines are recognized as authoritative by the major medical and mental health professional organizations in the United States. Other care models have not been recognized as standard practice, and some have elements that have been shown to do harm and that border on conversion therapy, which Oregon has banned. The HERC has the opportunity to ensure that Oregon's provision of gender-affirming care remains consistent with evidence-based practices in other states and countries. One more paragraph, okay. In considering policies that protect the right to medical care for transgender youth and respect parental rights, we need to rely upon trusted, well-researched guidelines to inform rules that will impact care. By utilizing version 8 of the WPATH standards, the HERC can support safety, well-being, and future gender diverse work guidance. Thank you for your time.
Thank you to Mr. Tredal, Dr. Silva, and Mr. Guerrero for being here today. As folks are aware, I want to acknowledge that we've heard comments related to gender affirming care now in multiple meetings. As a result of that, there has been guidance that has been sought from the OHA, and I'm going to turn it over to Jason to provide some additional comments.
Yeah, I'd actually like to welcome my boss, Krista Mars, to introduce herself and make a statement on behalf of OHA.
Hi, everyone. Krista Mars, she, her pronouns, and I'm the director of the Delivery System Innovation Office at the Oregon Health Authority. And I just want to provide a bit of background to this issue. In 2023, the Oregon Health Authority had asked OHSU's Center for Evidence-Based Policy to review the evidence about gender-affirming treatment. However, this review was stopped when House Bill 2002, which was passed in 2023, it was stopped due to the clear intent of the Oregon legislature to provide broad coverage for gender-affirming treatment. HERC's current primary statutory role is to produce the prioritized list of health services, which serves to guide coverage for the Oregon Health Plan. That said, statute based on House Bill 2002, which is Oregon Revised Statute 414.769, specifies that gender-affirming treatment shall be covered notwithstanding the prioritized list. The statute contains other provisions limiting the ability of Oregon Health Plan plans to perform utilization management for gender-affirming treatment when the services in question are medically necessary, according to the provider, and prescribed in accordance with accepted standards of care. After the passage of House Bill 2002, HERC had a responsibility to ensure smooth implementation of the law. To align with the legislation, HERC issued Guideline Note 127 to provide clarity related to legislative intent, with the understanding that the statute supersedes any guideline note that HERC would develop. HERC received public comments from several providers and a coordinated care organization requesting that HERC reference the WPATH 8 standard of care in Guideline Note 127. In response, HERC amended the guideline note to its current form. HERC has received public comments at recent meetings expressing concern about HERC's reference to WPATH 8 standard of care in Guideline Note 127, requesting HERC to create an evidence-based guideline on gender-affirming treatment under the authority in ORS, or Oregon Revised Statute 414.695, subsection 2, and to remove the reference to the WPATH 8 guideline from Guideline Note 127. OHA staff and leadership have been meeting to decide on next steps. We're taking the time necessary to identify the best path forward regarding the implementation of House Bill 2002 and Guideline Note 127 to ensure that members have access to appropriate gender-affirming treatments. We will proceed, guided as always by OHA's core values, including health equity, integrity, partnership, and transparency. Thank you.
Thank you again. Thank you, Chris, for being here with us this afternoon. So more dialogue will be coming back as the OHA decides and continues to discuss next steps in this direction. But I did want to provide an opportunity for any of the commissioners to make any comments or respond to any of the testimony that has been said here today. Hearing none, or seeing no hands raised online. Thank you so much for being here today, and we will proceed with the rest of our meeting.
Thank you so much.
Thank you so much.
Thank you for coming.
Thank you for coming.
Yeah. So the next item on the agenda is the approval of the minutes. Has anyone read the minutes and be positioned to make a motion to approve?
I so move.
Do I have a second?
Second.
Motion for the record, for the sake of the minutes and record keeping, motion from Lene, seconded by Dr. Schnabel. All those in favor, please say aye. Aye. So as a friendly reminder, if you are on Zoom, please vote in the chat. If you are in the room, please vote out loud. Good, let's, yep, okay. So motion is approved. And then next on the agenda is the BBBS report.
BBBS met this morning. We had a full agenda, and we unfortunately weren't able to get to several of the items, so I will point those out as we get to them, but they were tabled.
Wait a minute. I'm sorry, for the minutes, I see 3 ayes in the room and 2 online.
No.
Are there more? Oh, a couple voted before the thing. I'm sorry.
And votes are coming in the chat.
Wonderful. Okay. Pardon. Go ahead.
There are 6 eyes in the chat.
Great. Thank you. I just wasn't scrolling up far enough.
I actually now see 7 eyes in the chat.
Better yet.
Okay, going back to the BBBS report, we had our usual straightforward consent items. There was minimal discussion of any of those. They were approved as appear in your meeting materials. One additional item that was in your the rather large handout you all received on Tuesday was called excluded guidelines. Our current guideline note 172 and 173 are attached to lines below the funding line, and it's causing problems with hearings. And based on discussions with hearings and with the larger leadership at OHA, and agreed, the BBS folks also agreed to delete the 2 lines and change those guidelines to excluded guidelines. It's really kind of semantics, but it will help our hearings folks operationalize things. Anyone have any questions about that? It'll also help a lot with the benefit updates project, which you'll hear about a lot more in a little while. And then we had quite a animated discussion about home blood pressure automated monitors. We currently only cover the old-fashioned monitors where you need to use a stethoscope. Very difficult to use and kind of not really practical for most non-medically trained people. The question that came to us was whether OHA should start to cover automated blood pressure cuffs, which are the ones that you're probably used to, where it's a device that goes on your arm and then it reads out your blood pressure for you. There was quite a discussion. We had a person from the perinatal, Oregon Perinatal Collaborative who was talking about the impact of blood pressure issues related to pregnancy and the postpartum period, and how they're rolling out a program that that has people monitor their blood pressure at home, and then they're allowed, they can do a virtual check-in visit rather than having to come into the office, which is improving access. We had someone from the American Heart Association who came, who advocated for using the US validated device list, which is a list of blood pressure cuffs that have received validation through a process set out by this group, because these are considered to be more reliable. We heard from Ms. Ackerson, that some of these device lists don't contain enough access to extra large cuffs, so there's some debate about that, although members were able to find some on the list that did have extra large, so maybe a little issue there. The upshot of this whole discussion was that VBS agreed that we should add coverage for automatic blood pressure monitors, and we should put the codes, the HCPCS codes for those types of things on the ancillary file. Because they can be used for diagnosis of high blood pressure as well as for monitoring people with known high blood pressure related diseases. There was a change in what was in your meeting packet. The ancillary guideline that was proposed was modified to say that it's non-wrist monitors. The medical community is concerned about wrist monitors not being very accurate, so it says that non-wrist monitors are preferred, and that HERC prefers the devices on the US blood pressure validated device list when possible, leaving it open that they could use other devices if, for example, their local pharmacy didn't have a device that was on that list. Any questions about the changes from what you see in your packet? The oral health advisory panel report was reviewed. The CDT code placements were approved as in your packet, as well as the frenectomy guideline clarifications, which dealt with the CPT codes that are used by like oral surgeons, and the guideline note changes that we needed to accommodate those. The genetics advisory panel report was
So this is page 80 of the VBS packet.
was then discussed. We have a yearly update of our NCCN references. There was some discussion in the room about, the ability of HERC to just reference the most current NCCN guideline, but we heard pretty definitively that the actuarial and hearings and legal folks need a specific guideline. So the upshot is we're going to continue to reference a guideline. It's the last one that staff found before this meeting. We are aware that these guidelines may change prior to a year when we can update it, and CCOs are free to use the updated guidelines as expert support for their decisions, with the knowledge that almost always those guideline updates expand coverage. There were some new CPT codes related to genetics that were approved as presented. The prenatal genetic testing guideline, there were multiple different pieces that were approved for that.
Page 90.
They would add coverage for whole exome sequencing for prenatal diagnosis in limited circumstances, added coverage for testing of products of conception after the second or further pregnancy loss or when there were fetal anomalies seen, as well as we spun out the carrier guideline for carrier screening, which is when you test the pregnant person or person contemplating pregnancy as well as the male reproductive partner to see if they have they carry a mutation of a gene. That became its own guideline, mainly for ease of for staff keeping up to date. There were, in that guideline, we reference an ACOG guideline. It was brought to our attention that there's actually two interrelated ACOG guidelines, and we added a second reference, which will be, we were given the grace to wordsmith this slightly as, once we can get that guideline. Any questions about any of the advisory panel reports? Then we talked about the new CPT codes. There were quite a few of them. There wasn't a lot of discussion about any specific code, except the laboratory testing for neurodegenerative diseases. These are new codes for for tests that can be done on either the blood or the spinal fluid that you would get in a spinal tap, looking to see if people have proteins that are associated with Alzheimer's disease. Looking at the evidence and expert guidelines and being aware this is a very rapidly developing field, the recommendation in your packet was to add these as diagnostic tests with a new guideline that would restrict them to a very specific set of circumstances. There was a kind of a friendly amendment from our lovely pharmacist who's very aware of the medications we're dealing with. And so you can see on the screen, the initial recommendation had been for patients being evaluated for disease-modifying therapy. This is really for these new drugs that are coming out that typically have a higher risk ratio than some of the oral medications that have been used for quite a few years. So, and these newer drugs have FDA labeling requiring some type of biomarker testing if you don't do the PET imaging, which is the other standard. So we modified, as you can see, basically clarifying that for the disease-modifying therapies that are low risk and safe, that don't have an FDA label requiring, we wouldn't cover these tests. It's just for those disease-modifying therapies that have FDA labeling requiring them. There's mud. And then we talked, this was in your handout from Tuesday, the 2025 HCPCS codes reviewed. There was not a lot of discussion. There were a couple of staff options that
Page 19 of that handout.
that were presented. And just to let you all know what the decisions were this morning, there was one about cardiovascular disease risk and assessment. The recommendation was to put the management code on on 3 lines in addition. So that was it was a discuss adding, and that was actually considered to be the best option. And then for safety planning interventions, the staff recommendation of diagnostic was approved rather than some of the alternatives. So you saw those options in your packets, but just to call out what BBS decided on. And then the other topics had minimal review. We also were able to discuss the bone marrow transplant guideline that was approved as shown in your materials. The other topics that were either our biennial review, previous discussion, or new discussion items that have been tabled until January. Any questions about anything in the BBS report? Anything that people want to discuss further? Any other actions?
Looks like Mike has his hand.
Mike, do you have a question or a comment?
Yes, thank you. I wanted to see if the VBBS had a chance to review OHA, and Jason reached out to me as well, and OHA reached out as well, asking about the HCPCS codes for coming from for the MMIP diagnoses.
Yes. So what Mike's referring to is there are 2 new HCPCS codes that are referring to historical trauma for Indigenous persons for either missing and murdered or other trauma. And based on your input as well, Mike, thank you for that. They were placed on all of the lines that have psychotherapy. So any type of therapy diagnosis.
Okay, I appreciate that. So I guess Jason Steiner from OHA was asking, they would be looking for direction from HERC on the recommendation of how to use those codes, whether they're to be paired with another or if they can be standalone codes.
We can discuss that within OHA, but as far as HERC, the intent, if there is, those codes should not be denied. We want people to get those services.
All right, thank you very much.
Any other questions? I just say open up the floor for any other questions. Go ahead, Ariel.
No,
Any places you
you
want
said
summary?
it better than me.
Seeing nothing, so a motion to approve, is it a motion to approve as presented, as presented?
The VBS report.
So moved.
I'll second.
Saw some other hands as well. Were those questions or were those individuals looking to provide a motion?
I
Okay.
provided a motion and I think a couple people seconded.
Awesome, perfect. Okay, all those in favor, please say aye if you were in the room. Please vote online if you were on Zoom.
Aye.
Aye. Okay, the ayes have it.
That is, we're ready to go on to the benefit update project. Are you ready, Liz? So this is an update on what I presented last month, a little more detail. And then following this, we'll have an opportunity to look at some sample meeting materials. We're not going to get into the clinical issues, but we're going to talk about what you all need in order to make these important decisions in this new context as we look towards 2027. And as a preface to this, I wanted to say there is going to be a new administration in Washington, and some changes may come that we're not anticipating. This information is based on what we know today. We will adjust as necessary, based on changes made at the state level, the federal level, but this is our best plan as we know it now. So with that, let's go to the next slide. So just reviewing what we've gone on reviewed before, there will no longer be a waiver that permitted the use of the prioritized list. The intent was to maximize the number of people covered by being strategic about services covered. That said, the prioritized list is no longer used as a budget tool. The funding line has not moved since 2012 when the commission was formed. 97% of the people in Oregon now have health coverage, which is a record high. Under the prioritized list, there are some mandatory Medicaid benefits that are not covered, and this transition will be an opportunity to add coverage for some of those where they're determined medically necessary. HRC will continue to provide guidance, so this body will continue to provide the guidance on which services are considered medically necessary and under which conditions through this public evidence-based process. The mechanisms you are all familiar with to prevent undue influence by different parties will remain in place. Go ahead. Again, I'll skip that first bullet, but the second one, the waiver will end. Operational elements of our work will continue. The most important ones, evidence review will continue. Code pairing files, which currently give the lines of the prioritized list, will now become code groupings, and they will provide the same kind of guidance. Medical necessity policy will be expressed through guideline notes. HRC's public process will continue. Our values of transparency, stewardship, equity, evidence will continue to guide decisions. And federal law, even without the waiver, allows limitations based on medical necessity and utilization management. There is some increased cost expected, and we are not expecting, we are hoping there will be no reduction in the covered population or benefits as a result of this project. As we all know, other things can happen, but it won't be because of this project. The concerns for the Center for Medicare and Medicaid Services were that not all mandatory services were covered and members may not have full access to appeal rights in our fee-for-service system. Again, they recognize that the funding line hasn't moved for over a decade, the low insurance rate, and this is an opportunity to expand coverage. Let's go ahead. Just a few things from this slide are, so again, the waivers ending, lots of things will stay the same. HRC and program rules, we're expecting them to exist very much like they are today. There will be some necessary changes to reference things in the appropriate ways. Other medical necessity policies can be and are and will be continued to come from the CCOs. They have discretion in areas where HRC policy doesn't get to all the necessary nuance to make good decisions about medical necessity. That'll still happen. The difference will be that if a service is a covered benefit in the scope of our state plan, so for example, physician services are a covered benefit, they will need to be covered unless they are not medically necessary and appropriate or meet some very specific exceptions. There are also optional benefits. Those are, as the name implies, more optional, and that gets more nuanced at that point. But as a result of this, we do expect there to be some increase in covered services. We do not expect any of those optional benefits to be taken away from our OHP members. So just going to review briefly what we've heard from our member proxies. These are people who represent OHP members in different forums at the HRC. First of all, concerns about being able to access medical care. One of those is I can't find a provider in my community that's in my CCO. That is an issue. That is an important issue. Unfortunately, it is not something that is within our purview to address. There are others in the health authority and our CCOs who are working on those issues every day. We also heard concerns about the barriers prior authorization poses to accessing medical care. And that's something we try to keep in mind. If we create a coverage criteria, that can be a barrier. So let's make sure we have a good reason for that. There are questions about how things are going to be organized, how medical necessity policy will apply, how the things will be reorganized. There's just uncertainty. And so hopefully today's presentation will provide some clarity for you all and any members who maybe were attending. There's also some recommendations for members about educational and outreach efforts, which of course we want to do. We want to make this as smooth as possible and have people well informed. And then finally, recommendations regarding a new fee-for-service member-initiated appeals process that will be brought forward. I don't know the details of that, but there are others working on that at OHA. Again, I think I covered these points in response. So let's just go ahead. What we've heard from our coordinated care organizations, we've had several presentations to them. Far and away, I think the biggest concern we've heard has been about the cost and financial impact. I'll address that in a moment. How medical necessity is defined or determined, so that's a similar concern to the members. Heard concerns about potential for influence from groups seeking coverage of services that may not be the most safe or effective for our members. We've heard questions about services we don't usually talk about as much at HRC, including dental, pharmacy, and prescription. And those have some special nuance, which we'll get into a little bit later. Consider questions about how this body will make decisions about which services are medically necessary and covered. Also about changes to HRC products such as guideline notes and code pairings, how to process non-medically necessary claims, just administratively, how are we going to do that? What are our legal obligations? And then of course, the IT impact, that can slow things down, that can create complications and confusion, and we want to minimize that impact. See some responses there. Rates will be set. We are working, I've been working this week on budget implications, querying data, creating estimates, using that information to inform our topic reviews, making sure that information is available to our actuarial colleagues so that they can make good decisions about that. The rates will be set through the usual process and will be actuarially sound as they must be according to federal law. Any changes to HRC decision-making will be vetted publicly, including in just a few minutes from now, with meaningful opportunities for public input. Our goals at OHA include preserving the HRC's public evidence-based decision process, providing consistency across Oregon's many CCOs, and ensuring good stewardship of public resources. For pharmacy and dental coverage, for medications, if medications are being denied because of the funded funding line. So if the reason for the denial is not a funded OHP service, that will need to change. And so there may need to be some policy developed to decide whether those medications are medically necessary. That will not happen here. That will happen at the Pharmacy and Therapeutics Committee and OHA and at each CCO. For dental services, those are an optional benefit, and the same would apply to physical therapy, some other acupuncture, chiropractic, some of those categories that are optional Medicaid services. Those have a different process. For the dental benefit, we are aware that there are already some services that this body has determined are medically necessary, appropriate, and in the funded region. Unfortunately, our legislature has not been able to fund those, and we expect no change in that. So we expect really no significant changes to the dental benefit, although of course we'll continue to address new codes and update policy based on the latest science for the benefits that we do cover. The more operational questions, there'll be a CCO work group, which I'll talk about a little later. Again, those are just the high-level bullets of what people want to learn more about. Now let's get into medical necessity, and this is something that you all asked about last month, and I think in August and maybe in May, medical necessity and appropriateness. So first of all, terminology thing. The federal law, as we went over last time, talks about medical necessity. In Oregon, we actually have two related concepts, medical necessity and medical appropriateness, and there's also, I believe, dental appropriateness. And so when I say medical necessity in this presentation, I mean all those things. I'm using the federal definition, but in Oregon, it will be all three of those. We're going to review those rules. So the first one is medical necessity, Oregon's definition. So this is our current rule with some ellipsis because it's too much to fit on one slide. What I highlighted there in teal is some key concepts that you'll be familiar with from your work in this body. We look at services that address the prevention diagnosis of the client or member's disease, condition, or disorder that may result in health impairments or a disability. We look at the ability of a patient to attain, maintain, and regain independence and self-care, ability to perform activities of daily living, or improve health status. We don't often use those words, but I believe those are things consistent with the decisions made here. Medically necessary services must be medically appropriate. That definition is on the next slide, but I want to stick with this slide to see if anybody has any questions about how these highlighted things relate to how decisions have been made at Herbert. No comments? Okay, let's go to the next slide. And I should say EPSDT has its own definition, which is a little different for children. For this purpose, we're talking about adults age 21 or older. The medical appropriate definition has some factors that we also consider. Services must be safe, effective, and appropriate for the patient based on standards of good health practice, based on the best available evidence. Now, of course, we're not making patient-level decisions here. We're judging these things in this body at the population level. Are the services generally safe and effective and appropriate for the patients having the condition or meeting the guideline criteria or whatever, based upon the best available evidence? Not solely for convenience or preference. The most cost-effective of the alternative types or level of services. So these are the cases where we say, before you have surgery, maybe you should try some medication if that's appropriate. And it should be that should be done where the least costly alternative can be safely and effectively provided. Any questions or comments on that? Again, these words are a little bit different than the way we talk about things. But I think that the categories are very compatible, but legally, we will have to be able to tie anything we say is not medically necessary to one of these reasons. But there's substantial room for interpretation, and it's this body which will be charged with doing that interpretation. So Leslie.
Thank you. So I believe my term on the HERC is coming to a close, so I don't know if I will see a lot of this great work that's ahead of you. I just wanted to say one thing as it relates to the term solely for the convenience or preferences of the OHP client, member, or provider. When you're looking at that, it's really important to remember the rest of the rule, and the whole point of OHP services are often to allow the person to live their best life, right? And to be healthy and safe as well. What we see often with this idea around denials related to convenience or preferences is that sometimes when there's particularly a piece of equipment that might allow someone with a disability to have greater independence, sometimes that is seen as a convenience item for the provider. That oftentimes needs to be weighed with what will that allow that person to do in their life independently. So I just caution you in the future to remember that when you're looking at if it's for the convenience, to really focus in on, is this solely for the convenience of the member or provider, or is there also something else that can really make that person's life more vibrant and independent? So just remember that when that is seen really tightly, you see denials that won't make a lot of sense and that won't build people toward that independent life that they want. So thank you.
Yeah, thank you for that, Leslie. And we heard some of those concerns in our listening session for the disabilities panel. Durable medical equipment, we don't talk about much in this body. Those rules, those determinations, I don't think will change, except to the extent that if they're denied today because of the funding line, that barrier would go away. But I think most disabling conditions, I hope, are already in the funded region. But yes, that word solely is there for a reason.
Yeah, I just have one other quick question, Jason. You made me think of when I first started at the HERC, there were some kind of general HERC like agreements that we'd come to, and I was wondering if HERC is going to create some sort of a medical necessity kind of group agreements or format. So when these things do come to this body, members have a sense of how to weigh and evaluate this, since this will be relatively new.
I'm not sure which agreements you're referring to.
Yeah, Leslie, can you tell me more? Because I think you and I joined about at the same time. And so as you were making that comment, I was trying to
do you remember
connect that with my experiences? So I would be open to tell me more, please.
Yeah, it was a PowerPoint, Adrienne, when we first joined, and it was when we were really talking about weighing the patient preferences versus not strong evidence. And so there were it was a PowerPoint that we all discussed, and it was really based on how do we make our decisions? How do we put ourselves in the shoes of patients when needed? How do we balance that with evidence? And it was probably around, Adrienne, maybe like the first 6 months or so that we were on the HERC, but it was really reminding us of how to handle some of these situations that were maybe a little trickier.
Was it at the retreat that happened in like Lake Oswego on like a college that has, okay.
Marylhurst student.
Yeah, so
I'll have to look back at those meeting materials. I did bring something like that to our last meeting, but we didn't really get a chance to finish discussing it. I'm hoping we get a chance at a future meeting.
Yeah, it might just be good as you're looking at medical necessity and policies for the HERC, just something to think about. Thanks.
Yeah, I'll look back at that. Thank you.
Yeah, there's been some conversations that have been happening kind of with leadership of HERC as well as BBBS, EGBS about how do we grapple with some of these spaces where there is maybe less robust evidence than we would like as we are trying to make decisions, and how do we bring in those value and preferences and really everything that you're talking about. So it's just interesting. It's just an echo of a comment that has been a discussion that's been happening, and maybe that would be a presentation and a resource for us to go back and to look at and to see if maybe there were some resources and some lenses on that conversation that existed, 8 years ago as we're grappling with still similar issues.
That's great, thank you. And I'm gonna have to switch to the phone, just so, Jessica, if you see me hop off and then hop on again, that's why. Thank you.
All right, thank you. If you could message me the last like 3 digits of your phone number privately so I know which number is yours, that would be helpful.
Sure.
Any other comments from the commissioners, either online or in the room?
I had one, just listening to Jason, you this time versus in BBBS sounded a little bit different in almost saying like, this transition is certainly not intended to decrease the roles of members covered by Oregon Health Plan. I appreciate that, but I don't know how, I just want to live in like a real place where there's only so much that the Oregon Health Plan can do, and that this change radically reorgs and puts a whole bunch of things that were like what we call below funded line now into, funded areas. And I just, to me, just my logical brain is having a hard time understanding how this isn't going to be a huge change, either vastly and drastically more expensive or, cause things like decreasing the number of lives coverable.
Yeah,
so you sounded pretty confident that's not going to be the result of this program.
So,
I'm grappling
there will
with that.
be additional cost. The legislature will need to figure out how to fund that, just like they do in every other state, just like Oregon does currently when a new pharmaceutical agent is developed. And they will need to figure out where to come up with that money, whether through tax increases or cuts to other programs or whatever. But this project, our job is to determine what's medically necessary, and medically necessary services must be covered. So good stewardship will continue to be important. We don't want to be wasting those monies that could be dedicated to other important state services. At the same time, it will be our obligation, if something is medically necessary in the judgment of this group, to cover it.
And then that brings back to the like medically necessary versus covered benefit, question that.
Yeah, we'll get into that in just a minute.
Perfect.
Okay, other comments or questions? Okay.
This is Chris. I just want to make sure that we include kind of that same idea of like the plain language summaries when we talk about how these things are framed.
Yes, absolutely. We plan to continue those even without, unfortunately, Daphne being on leave. Ariel and I were able to do plain language summaries for almost all the issues this meeting. Hopefully we'll have Daphne back in her seat and be able to do that. We even talked about some ways to enhance that, to make it more clear what you're deciding on, both for you as members and for the public to understand what the key issues are. Sometimes we get lost in lots of detail about things that are not controversial. We'll try to highlight the key decisions for you as much as we are able.
I think the switch to the language that I've been hearing, it does sound more consistent with like we're getting in line with what all the other states are doing, and that it seems reasonable to start speaking of it as like a benefits coverage package of what's covered and not covered. And I think being transparent about what is a financial limitation versus having everything fall under that first half of that of medical necessity. I think if we can just keep that on the table to be transparent, I think that it'll be a lot more clear for the public.
Yeah, and that will need to be clear on the denial notices. Is it denied for medical necessity or is it denied because it's not a covered benefit? Those will be two different messages. Looks like Mike wants to say something. Oh, no? Okay. Just stretching your hand. All right.
I'm just stretching my fingers, yeah.
It's all right. We all need to take care of our body. All right. So based on that statement, and if any of you disagree with that, I'd love to hear about it, either now or after the meeting. I don't expect our decisions and standards to significantly change because of this project. We'll still be looking at the same factors, looking at things that are safe, make people's lives better, still looking at stewardship, valuing safety, wellness, good stewardship. We will still create very similar deliverables, and we'll have examples of those. Cut code pairing files instead of prioritized list pairings, coverage guidelines instead of guideline notes, statements of intent will be similar to how they are today. Program rules for durable medical equipment and mental health, those will remain largely as they do today, except where they reference the prioritized list, and then there will need to be some changes. There's some more things that'll stay mostly the same. CCOs must and will continue to need to cover things identified by HRC as medically necessary. Currently it's only in the funded region, but now it'll be everything, as they apply to the member's circumstances. CCOs can deny services HRC has said are not medically necessary and appropriate. Where HRC has made clear policy, said under such and such circumstances, XYZ is not medically necessary, CCOs will be able to rely on that to support denials just as they do on our guideline notes or non-pairings today. And CCOs will continue to have discretion to make exceptions if appropriate based on the similar circumstances. Comorbidities, unique patient circumstances, contraindications, late-breaking evidence. We hope CCOs are using that when it's appropriate to do what's right for a member. Where HRC is ambiguous or silent, just we don't get to that level of detail or whatever, CCOs can and should be using medical judgment and external resources to inform those decisions, and can always ask HRC to make a decision if one is needed at this level. As a result of the transition, again, the funding line goes away, the ranking goes away, the denials based on the funding line go away. Comorbidity rule exists because it is only for services in the unfunded region. What will continue is the reliance on HRC for consistent baseline coverage for all of our Oregon CCOs and our fee-for-service program, reliance on HRC decisions to support denials of care that's not medically necessary, CCO discretion to use external supplemental resources when appropriate, and CCO discretion to make exceptions when appropriate and cover things that may not meet the letter of what HRC did but are the right thing to do under the circumstances. All right, now we're going to look at some samples of HRC policy and what the transition is going to look like. So this is an updated slide of what I showed you last week. You can see that yellow line that kind of makes a pitchfork. That's going to be our job to split things into not medically necessary and newly covered that are in the unfunded region. Then there'll be another category that will be non-covered, not included in the state plan. And currently those, when we say we're not going to put something in the funded region or not going to pair it, it kind of muddles those two, the yellow and the green there. We're going to have to be specific about what those are, and actually OHA will be making the decisions mostly about what's in the green area. They'll listen to your recommendations, I'm sure, but OHA, the legislature, will need to be involved in those kinds of decisions, especially with regards to optional benefits. Go ahead. So here's an example line on the prioritized list. I picked one of the ones with fewer codes on it just because slides are small. But you can see we won't call it a line, we'll call it a code group. We'll give it a different number. Instead of a guideline note, it will be a coverage guideline. Instead of lines referenced with the coverage guideline, it'll be code groups. And you can see where it says medically necessary there in the bottom. Currently it says, all those things on the first line are included on this line. Instead, it will say are medically necessary. And it goes on and on and on to describe those services. But the criteria, the actual substance of the policy for the funded region should be very much like it is today. It's just more changes in nomenclature, and we will have to make some adjustments, believe me, just for consistency, and so things will work. But we're not going to revisit every policy on the prioritized list. There's only so much time in our meetings. Here's a sample HERC recommendation. You can see this is a sample we'll look at in more detail a little later about allergy testing. So Ariel looked at all the below the line allergy diagnoses. There'll be an evidence summary just like you saw before, then there'll be staff recommendations, and they'll look largely like they will before, but they'll use the new nomenclature. Go ahead. And there's a sample new coverage guideline. Again, the language is very much like what you see today. Just referencing the new structure. There will no longer be references to lines in the unfunded region. There's another one on allergy treatment. And you can see we added a date of last review. So people, CCOs, when they're making those decisions, can tell you, is this from 2012? Maybe it's time to review that. Just make it more transparent. And there's a coverage guideline on food allergies, which are different than the other allergies and have different criteria. And there's a list of codes, a table. You can see the current placement column has our lines on the prioritized list today. We present that to you so you can understand what's going on. So line 494 is in the unfunded region. That will be moved to 2 code groups of allergy testing and allergy treatment. And you see the last row there is only on the food allergy testing and treatment lines. And then additional diagnoses will be recommended but are not shown here. There'll be similar tables for the procedure codes. Prescription medication criteria for medications would be updated to remove references to the funding line or prioritized list. If you're an IT person and you're on this, you'll be interested in the Oregon data files, just showing you there the structure will stay the same. The names of things will be changed to align with what they are. Okay, now we get to this distinction we asked about a moment ago. So not medically necessary versus outside the scope of the plan. Let's actually take the second section first. I probably should have done this slide the other way. I call this the off the table group. We do not cover under OHP infertility services, full stop. We do not cover GLP-1 for weight loss, full stop. We do not cover dental crowns or root canals for adults, full stop. We do not cover eyeglasses for adults, full stop. All of those services are important services people want and need. There's not that much debate about effectiveness, except perhaps for the GLP-1. These are funding issues, and in order to cover those services, we would need money from the legislature, and federal law allows Oregon not to cover them. That's why some of the things, the dental crowns and root canals, are not covered today, despite HERC's recommendation to do so. Everything else that falls into those mandatory categories must be covered when medically necessary. So if we made no specific policy and applied no medical necessity policy, platelet-rich plasma for knee pain, epidural steroid injections for back pain, excision of the frenum for tongue tie, spinal fusion for a person without nerve impairment, all those things would need to be covered because they are physician services or dentist services in some cases for the tongue tie. But some of those are not medically necessary, and so we need policy to support those denials, and that will be the job of this body to ensure that we're not spending state resources on those or providing ineffective or unsafe services. Stacy, I see your hand up.
I clicked the wrong button.
Okay.
Great presentation. I just want to ask a couple of clarifying questions regarding the dental, and I understand the federal exclusion. I'm on call this week for Providence St. Vincent, and I just got finished taking care of a patient who has a lot of very serious medical comorbidities and who required urgent surgical intervention from infection coming from her teeth. My previous call cycle, I had a patient who had a brain abscess that developed from teeth. So I guess I'm just a little concerned, or I guess maybe confused, or just asking for clarification is how is OHA going to accommodate the needs of these patients that end up with pretty severe outcomes where they're requiring ICU care and so on, and all coming from dental infections. And when you talk with them and you get their history, it's often that they haven't been able to get a root canal, or so maybe it's an unfair question, Jason, but I do have concerns about this. And I hear what you're saying, and I get it. I'm just wondering how we're going to handle, or is there any way we can carve out benefits so that people don't end up with these severe infections? So that's my question.
Yeah, so I believe that's one of the reasons that our coordinated care organizations now incorporate dental health. They would have the flexibility to do that. However, at a federal level, bottom line is OHP, the legislature has not chosen to make those services a covered and funded benefit, and a change would need to be initiated in the legislature. And that's one of the most frequent things Daphne hears in the listening sessions. We hear it in our ombuds office. We know it is a huge concern for many OHP patients. And unfortunately, those outcomes happen. And it's just, this body does not have the power to tax or to cut other programs or to print money, and that is just the system we work within. Any other questions or comments?
This is Leslie. I just have a quick comment about the dental. I know we've been around this before, but I think it's really important to think about not only the medical outcomes of people, like we were just discussing, that have expensive issues come up, but I think it's also important.
Hi, Mark. We're getting some feedback.
Mark, can you mute, please? Thank you.
Go
ahead, Leslie.
Yes, thanks. I think it's important to think about when you're looking at ending health inequities, there is a duty, I believe, from OHA to provide these dental services to people, because not only does it have a health impact, it has a huge social impact. It has an employment impact. When you have dental issues, we hear from people with disabilities all the time how that plays out around not only their stigmas with disability, but now with dental as well. And it does make it much more challenging socially, and more equally importantly in the employment setting too. So it does have much broader implications than simply healthcare. So thank you.
Yeah, thank you, Leslie. We are aware of those, and we elevate those to OHA leadership whenever we get the chance. Unfortunately, reality is what it is as of now.
Yeah, and it's not just OHP. Medicare also doesn't have a dental benefit. I have a patient right now who's going to transition to Medicare, and he is cramming in all of his dental in the next 6 months.
All right, Mike?
Yeah, I just thank you. So I just wanted to add on to Leslie, and it isn't just the social effects. There are other health issues that arise from that, and one that isn't discussed is the behavioral health issues that arise from dental issues, right? And I'm not talking about getting the infections and having a brain trigger. I'm talking about them not having the ability, one, to find employment because of their physical appearance, but that in turn affects their mental health. Then they slip into a depression. They slip into other mental health issues that are directly related to dental services that could have been covered. And I understand where our hands are at on this, and I get that as HERC, but I think it is also, probably the responsibility of OHA to be more of a body where they're in meeting with the governor, where they're in meeting with the legislature, to have those voices in the right circles. And I think the only way they're going to do that is through education. So those are my comments. Thank you.
Stacy?
I'm wondering, Jason, does the commission have the ability to write a position paper discussing the importance in terms of equity and just how important oral health is, so that that could be given to the legislature and various political groups could work with lobbyists? I know that's not necessarily our position, but can we talk about how we feel that oral health is important?
I'll take that back. It will be part of this project, but there may be something new. I know our Ombuds office created quite a report last year about these kinds of issues, and I know it got elevated. So HERC could add its voice to something like that. I certainly think we
Well, it's interesting because we are evidence-based. Like, I'm an epidemiologist. We have lots of smart people in the room, and there is very strong evidence linking all kinds of outcomes to oral health, social, emotional. And it's interesting. We could, if we wrote something, perhaps, that would help with some of the things you're hearing in the listening sessions, that we are in favor of promoting oral health. We think it's important. We see the relationships. We're just, there's issues with funding.
Yeah.
I don't know, just a thought of something positive that could be done to affect change, possibly. And thank you for listening, everybody.
Yeah, thank you. I will follow up on this. Other questions or concerns about this distinction between not medically necessary and not in the benefit package? Currently, those are kind of mushed together. They will need to be cleaved. All right. Next slide. So again, key takeaways, those administrative rules we looked at are not changing as a result of this project. A lot of the things, those other bullets, are very similar to the way they are with the prioritized list. Mark, can you mute again, please, if you're not speaking? Thank you. In the transition process and going forward, we expect HERC will continue to be an independent governor-appointed commission confirmed by the Senate. HERC will continue to use its evidence-based, transparent process, balancing participation between members, CCOs, providers, and other parties. We will continue, of course, to consider equity in decision-making, and HERC deliverables will evolve with only necessary format language changes. Now we get to how decisions will be made. Let's look at our work plan. First of all, again, we're hiring a medical director. We were able to do so. Ariel has been doing an amazing amount of work meeting with specialists. So far, you see almost 10 specialties there in that first sub-bullet. Several more to come, and it wouldn't surprise me if some come out of the woodwork. In addition, there's the whole area of primary care, which she's looking at herself. We'll consult with some others as we bring those recommendations. If there are other groups you think we should meet with, and you being anyone on the call, please get in touch with us and let us know. We want to as much information as we can to inform our review, so we can focus on the right issues that are important to our members and our plans and our providers. We will be bringing proposals to the CCO work group and HERC during calendar year 2025, so buckle your seatbelts. It's going to be a fast and furious ride. And we will coordinate with actuaries and budget to ensure they have accurate information to plan the necessary funding. Go ahead. We will release a tracker early next year. and put it on our website so people will know what to expect. The goal is that all significant decisions about below the line services be complete by December 1. We may need an extra meeting to accomplish that. Whether that will be a VBBS meeting or a HERC meeting, or whether we enlist EBGS to help some of those decisions remains to be determined. The meeting materials will include detailed code pairings and guideline text, decisions in the minutes, much as today. We hope to have a preview of the draft deliverables, you know, the thing that replaces the prioritized list, which we don't have a good name for yet. The thing, the entity. We'll have a preview version, but then we'll continue to maintain that along with the prioritized lists, you know, as policy evolves. So there'll be a little bit of parallel work going on. And the final version should be published December 1st, 2026, because there will be CPT codes and HCPCS codes released late next year or late that year that we'll have to incorporate. But the most of it should be done well before that. We will be consolidating in the process because we won't have prioritization. There will no longer be need for our 600 and some lines. We can combine some of those. We're going to focus our work, our guideline development, our paired work on things that have potential for waste or overuse. If something is low cost, if it's a rare condition, if it's a lung resection that nobody in the world would perform or want performed, if it's not absolutely necessary, then we'll just cover that, put it on the consent agenda, and move on to something that's actually worth spending your energy as volunteer commissioners on. Try to get some of those non-controversial things out of the way so that that's all out there in the public space. If somebody disagrees with our decision that it's not controversial, they can say so. All this will be vetted through the HERC process and in CCO work groups, final decisions confirmed at HERC. Our fee-for-service pharmacy team is doing a similar body of work, looking at all the places where their criteria reference the funding line, similar kinds of timelines. Their work sounds like will extend into 2026, where we're hoping to be faster than that. But then there will be continued refinement ongoing.
Jason?
Yes.
This is Chris. If could you go back to slide 33 real quick? I'm just wondering, when we talk about focusing on waste and overuse, and we're also thinking about the bigger goal, could this be a place where we also use an equity lens and just have that as part of our lens when we're looking at these things?
I hope that it is. If there are specific
33.
ways you'd like us to do that beyond what we're already doing, let's have a conversation about that. Is there something in particular?
That second bullet point, focus guideline development on procedures with potential for waste, overuse. And if we added equity there, I think it just gives us an opening to be consistent with the goals of the OHA and keep that lens open.
Well, so the reason for that is that the default, if we don't look at something, is that it would be covered. And equity considerations usually slant in the direction of coverage rather than non-coverage. Does that make sense?
I think so. Say it one more time.
So that the reason we focus on the things we want to limit.
Okay.
And other things will be covered. And so that's the reason that was done that way. And equity is one of the reasons for that, right?
Yes, thank you.
So, yeah, but where there are equity issues, absolutely, we'll want to highlight those and bring those forward, and we'll welcome your help in doing so. Okay. Let's go ahead. This is our timeline for our overall project. That's there for your reference. As you can see, there's a lot of work streams going on beyond our little HERC world. Next slide. And there will be other opportunities. There will be CCO work groups, Quality and Health Outcomes Committees. There will also be a continued member proxy engagement, as well as public meetings for any OHP member to attend. In fact, we had some OHP members on our CCO work group the other day, so people are engaged. And if you have questions, you know where to reach us, herc.info. or these email addresses here. There's also a special OHP benefit update project, which is indexed on Google. And you can reach, and that'll have frequently asked questions, other kinds of project information, which will be updated as time goes on. Okay. Any other questions or discussion before we move into some sample policies around allergies?
And I'm sure you're gonna have a lot more input when you see sort of the sort of proposal of how this is gonna look, so definitely you have more opportunity to jump in.
Yeah, I think it'll make a lot more sense as you actually get your hands on the proposals and have an opportunity to interact with them. So let's move to that. And please provide feedback now. And again, if you think of something 2 days from now and wonder about it, please be in touch. More information sooner, circulate it with colleagues, discuss it at happy hour, if you have those still, because it'll help make it better for all our good.
Do you want to UP allergy or the allergy thing for November? UP allergy.
We didn't get to the.
Yeah. So the goal of this is not to make a decision. My hopes, my goal for this section is just to show you what one of these products would look like, kind of socialize how it's going to be a little bit different. And then I got a lot of really helpful input from PPS this morning, and I can kind of share a little of that with you, and then any other input you have. So the documents are going to look a little bit different. They mostly will not have evidence reviews like you're used to or expert guidelines or anything. If it's something where we're really just converting current policy to the new format, you'll just kind of see that. I was asked this morning to really try to figure out how to highlight or call out where the pieces are that might need your input, your discussion, and where things are really just cleaning up things or pretty straightforward. So what you have in front of you is I met with the allergists, and this is probably the one that's furthest along toward being something that's ready for you all to make a decision about. So I brought it as an example. Do you want to go down, Liz? So in this particular, just go down to like the stat recs. In this particular one, what you'll see is the expert input, and that's who I've met with. So I'm having meetings with one or more people in a certain specialty. But then sometimes that spins out and they ask me to talk to someone else. So like, for example, I met with a group of ophthalmologists and there was nobody who was a corneal specialist. So they asked me to reach out and have a meeting next week with a corneal specialist. So you'll see a list of people that I've met with, and they may or may not have had a lot of input, or we just were asked about a couple things, but anyway, you'll see their names. I will try to summarize the issues. I heard quite clearly this morning that there's a need to maybe break out the staff summary and staff recommendations. So what we have been historically bringing you is sort of a 1 or 2 paragraph summary and then maybe 4 or 5 staff recommendations. This is probably going to be more. And what I heard this morning was the first part of the staff recommendation will be housekeeping items, particularly if there's a change, like talking to a specialist, we discover something that should be changed sooner than 2027. There's an important diagnosis that's not being covered, or kind of a silly barrier to a lot of their care that we could fix now. I will call that, I'll just kind of put like, housekeeping items, and then a lot of the just sort of straightforward things that are just gonna kind of convert over. That'll just be one section, and we will plan to not discuss that unless obviously somebody calls out an issue or a diagnosis or something that they do want to talk about. Just like now, that will happen and we can talk about it. Then what you'll see is I'll try to call out where there's some discussion. So for allergies, talking to the allergist, there's really, stepping one step back, right now, any diagnosis in the non-funded region is funded for an office visit. So if you have allergic rhinitis and you see your family physician and they say you have allergic rhinitis, here's a prescription for Claritin, the office visit and the Claritin is paid for. If there was an incredibly expensive, possibly dangerous IV drug for it, that would be PA'd and it would be denied. But cheap stuff, things that aren't worth PAing, are probably just being paid for. So underlying all of this is all of these diagnoses get office visits. They all get medications that we aren't putting energy into restricting through PA process. And then on top of that, for allergies, the allergist identified basically 3 areas. So there'll be 3 what we're calling code groupings. One is for allergy testing. So if you have a allergy to zinc in costume jewelry and you have an allergic reaction on your skin, they can test you to figure out what you're reactive to and then you can avoid it. There are things that need both allergy testing and allergy shots, and that would be in a group. It would be in the allergy testing group and the allergy shot group. And then there is a whole different world in the allergy space about food allergies, and that would be its own code grouping. One diagnosis might be in multiple code groups if it's worth testing and treating. It may only be in one if it's just testing is necessary. If you want to page down a little, go down to the first table. So what you'll see is all of the codes. So I also heard this morning a need to highlight big changes. So if you'll notice on the top 2 lines, it's like conjunctivitis, which those first 3 actual lines, or actually the first 5, are things that we currently don't pay for other than those office visits. So that would be a big change. Allergic rhinitis and conjunctivitis would now have allergy testing and treatment. And also conjunctivitis will come back to you in the ophthalmology group because especially the pediatric ophthalmologists are saying that they get asked to look at this all the time and they want their ophthalmology visit codes covered. So if you would like, I can maybe bold, or we could do some, or maybe separate in the table like new coverage versus if you look at the next few lines, like asthma and edema of the larynx, those are currently covered, but we are going to put them into this new code group. So we could figure out a way to differentiate that just to make it really clear to you what's moving as just ways of making things nice and neat and not having things pair anymore on lines that don't make sense. So we're pulling just the diagnoses off that line to be allergies kind of stuff. And if you have ideas of how you'd like that presented to you, please let me know. And then if you can get on Liz. And then, so this is all the diagnoses. And as you can see, they're above and below the line. And then there will be a set of procedures, CPT and HCPCS codes, that will be on another table like that. And this is where they're going to be in their like code group kinds of things. And you know, it'll show you. And then they will no longer appear. So if you look at allergy, IgE, the second line there, that test is on multiple lines. And I just realized an error. We have 2 of those things that we specifically exclude because they don't work. And the allergist told me not to cover them. And I put them in the code group. So anyway, that highlights for me, I need to look at these one more time. So if the current thing is excluded, we'll continue it unexcluded. But some of these you can see are on covered and uncovered lines. They'll be pulled off, those covered lines, because a lot of times there's things on that line that aren't appropriate for that procedure or that test. So, so in that way, it'll kind of, I think, clarify some coverage. And all of these are currently covered, except for those ones that I didn't notice that were on 654. That will not be on there when you see this in January. Then so that's the second thing. You'll see the ICD-10 codes, you'll see the CPT codes. And then the third thing, which isn't really in order just because these tables are too big, will be guidelines. These guidelines are 80% based on current guidelines. A lot of these will just be current guidelines changed over. And instead of saying, this code is included on this line for, it'll say, treatment of this diagnosis is medically necessary for. And we heard that it would be important to say things like allergy desensitization is not medically necessary for ICD-10 codes not appearing in this code group. So we'll continue to do that. There will also be a date of last review, which is one of the things the CCOs have been asking for a while, just because it lets them know how up to date the guideline is without going through our minutes. So that will be another option, another thing. And then if you could go up just like halfway, no, yes, there, there. So this guideline is our how many allergy testing that we do. We currently don't limit the number of allergy test units that we allow, and that was one of the things the allergists brought to my attention, that they think there's a ton of overuse in the community, and they actually asked that we write in some limits. The limits are pretty generous according to the allergists. These are probably more than what they would like realistically need, but since we're reducing our current benefit, I thought that erring on the generous side was better. So this is not the current guideline. So what I would do when this comes in January, the first thing we'll talk about is, I met with the allergist, they want us to put limits on some of the testing because of overuse. This is our proposal. Have a discussion, have input, changes, whatever you all feel are needed. Like this morning, it was discussed that the word time, like 60 times is in there. It should probably be 60 units. You know, that's all the really important feedback that we'll use. Once we get, so that will be a one document, and it will be right after will be all of the allergy BUP. And as you heard from Jason, we are going to have two side-by-side products for a couple of years. So you'll see the prioritized list changes, and then we will just have it as a standing understanding that if you change a prioritized list guideline, the BUP corresponding guideline changes exactly the same way. So when we talk about allergies in January, we'll talk about limiting allergy tests. If there was some other controversial area that, for example, the breast surgeons and I are having a rather vigorous debate about a couple of breast surgery issues. I may or may not end up agreeing with them. If I don't, I will definitely bring that as a separate item. We will invite anyone who wants to come and testify, just like we do now. You guys will make your decision. And then we will talk about the BUP. We'll do the straightforward stuff, and then anything controversial, and then calling out where there's going to be new coverage, like the allergic rhinitis will get allergy testing or whatever. You can all at that point say, wait a minute, I am not comfortable with this. I would like you to do an evidence review on how much treatment of allergic rhinitis affects quality of life, and then we will do that and bring that back to another meeting to inform our discussion. Tons of information I just threw at you. What do you all think? Input? People who are here this morning, did I get your asks okay?
Yeah. So I think pretty much everyone in the room heard this morning as well. So I guess the question is, for those of you online, are there reactions that you're having initially? Does this make sense? Does this not make sense? Is it too late in the afternoon to think about this?
And partly also just to socialize you to the different appearing things that are going to come, that you're going to have to be able to process a bit.
I appreciate the work that the value-based committee has done on this and evidence proven here. I think allergies has always been such a tough area of doing testing, doing follow-up, doing the serums, so I think it's good that this is happening. And I think it's good to have it side by side for a couple of years. And it's good that you've had the allergists themselves having input on this. So that we're not, chasing a ghost horse. So I appreciate you guys' work on this.
Thanks, Mike. Lene, your hand is up.
I just want to echo what Michael said, that this is a tremendous amount of work. It's a very heavy lift. And if we, and I appreciate that we're trying to be as thorough as possible. And I think that we're going to have some errors and omission kinds of things that we're going to have to be in a corrective mode. So I think having two things side by side and then recognizing that there'll be the nuanced pieces that we need to keep picking up and working on is going to be important work for us to hold ourselves accountable for clarity, because I think this is what's making people nervous, is this shift and wanting to make sure we have as much clarity and detail. So appreciate all the work. Know there's more work, and want us to be mindful of that.
Yes. Go ahead, Mark.
Oh, no, I wanted to recap what others have spoken, but thank you for all the extra work. And,
I'm having trouble understanding you. I'm sorry.
Can you hear me better now?
Yeah.
Oh, no, I just wanted to recap that. Thank you for all that work, that I think this is an excellent way moving forward. And just wanted to thank you.
Thanks. Thanks for the comments, Mark. And I'll just echo that as well. After having seen this for a second time, I was hoping the second time would make me feel like this is a little bit more streamlined and ability to crosswalk, and not as, I think, laborious as it's going to be, and just how detail oriented it's going to be. So I'll just say thank you in advance to staff who's going to be working on this tirelessly for the next 12 months, 24 months, however long this takes. So thank you in advance.
Yeah, I'd just like to highlight one issue that I asked this morning and I highlighted. And it's about the clinical decision. So there are a number of the things that are below the funding line are less severe diseases. So we've got viral warts, we've got allergic rhinitis, actinic keratosis. Did I pronounce that correctly? Those are things many people want services for, nobody's gonna die from. They are prioritized low on the prioritized list for that reason. And we would need to balance the need for stewardship with the desire to cover medically necessary services. And that discretion in applying those principles that are in that medical necessity and appropriateness rule will be here. And so in the past, we've looked at things like impact on function. We've looked at clinic impact on disease progression. Does it cause something worse? We don't want that. We've looked at impact on quality of life. We've looked at impact on, what am I missing, Ariel? But we've looked for patient important outcomes. We've looked for not just statistical significance, but actual clinical difference for the person. Are those the right kinds of outcomes to be looking for as we bring those kinds of things? Because it will impact the cost. How on a pendulum or scale between strict and there's a range of decisions this body can make, and that can be difficult. So what kind of information can we bring?
But what pathway would we have to not cover those things, given this framework? We have to put them in the not covered, define them as an uncovered benefit.
A lot of times it'll be office visit only.
Which is, but just stating that it's not medically necessary or appropriate.
Right. You could say it's never medically necessary. Like for warts, for example, you could say it's never medically necessary to remove wart. You can say only if it's impacting your ability to wash or walk or wear shoes, or impacting your daily living, or if it's on your face or hands, or like there are things like that you can do. But ideally, I'd like us to bring proposals that either a proposal you're likely to accept or options that you can choose from. And the relevant evidence to inform that decision about any of those things. Some of these are, obvious to everybody. Some things actually might benefit from an evidence review, but if you have any input on that, either now or in the coming weeks and months, we really appreciate knowing that we can prepare adequately.
Yeah, and then
This
there's
is Chris. Oh, sorry, go ahead.
No, go ahead, Chris. Go, Chris.
I'm wondering, when you ask this question, I keep thinking about some of the conversation we've had earlier about medical necessity versus these other larger pictures of the overlap with dental, the overlap with mental health, and if there's a place here to, label holistic health, or even I also keep thinking about, like with, I guess from FQHC models, we're required to have, half the board needs to be patients that are receiving care there, and where that patient perspective might find a voice here. I see it being considered through public comment, but also maybe like the volume of the comments, or like, I'm not sure how we can include the member's voice in this process.
Yeah, I'd like to echo that, Chris. I think one of the things I'm getting stuck up on is the term, the phrase medically necessary. My whole career is elective medicine. Almost nothing that I do is medically necessary, but it's extremely important for people. But I would never say it's medically necessary. In fact, I explain that to people all the time, how unnecessary. It's not needed. Like, nobody needs to have a lot of healthcare. So we're saying these things are medically necessary or not medically necessary. And I think that's almost not right, because neither of those phrases either can really bring in and capture values and preferences. So I think just the terminology that we're being shifted to, I think changes the framework a lot.
Let's talk about that, because
terminology.
during the pandemic, this came up.
Like it.
When they canceled elective surgeries, I knew somebody whose cancer surgery was canceled. We're not talking about that definition of elective here in this context, I hope.
This is Chris. I guess I'm just really trying to see the perspective of our members and how that language will come across. And I think we have an opportunity to actually, as we have been doing, set the bar in being transparent and just being honest about, what our limitations are with the program, instead of putting it in that category. And we have an opportunity to also consider holistic health and these other aspects that we do know impact equity and people's overall health. We may not be able to actually change the decisions necessarily, but I think it really speaks to us being transparent and really keeping that bar of understanding that health isn't just medical. It's all of these things put together. And so it's an opportunity for us to build a window for it, but also I think to validate a patient's experience and let them know that they're part of the consideration.
Yeah, and so we'll continue to have our listening sessions, although unfortunately we had to cancel our December one due to Daphne's absence, but maybe we can make that a focus of where we get that information and convey it here. People are always welcome to attend our meetings, although I know that's intimidating for a lot of patients. Hopefully those can be a little more approachable in those listening sessions. If you have other ideas, Chris, on how we can do that, we're all ears.
And
I think that's a great place to bring this phrasing to, is a listening session.
The bigger BUP effort, which is bigger than HERC, I know that they are planning some member sessions of some sort.
I think there's some reach out, there's CCR reach out, there's clinician reach out, one or two, I think.
Thank you, Mark.
Lene, we see your hand.
So the way I really appreciate Chris's comment. We want to be moving progressively and finding language that's accessible. And then we also get caught in this tension with how does this fit in with how other payers across the country or other services, whether it's Medicare, Medicaid, or commercial, that term medically necessary is kind of entrenched in that culture and in that language. So how do we have transformative, inclusive language, and how do we also still communicate with others what we're being asked to do. It is a bit of a change for us that we're being asked to be more in conformity with other national and other states' Medicaid plans. So I think there's we want to be responsible to the people who we're serving, and we also need to be able to communicate with others what we are or are not doing. So I was just thinking about that as you were talking, Chris, about like, where's the place where we find the transformative language that allows us. We have this tendency, I always have this joke about organizing everything. And sometimes when we organize it, we opt ourselves out of the national conversation. So I just want to be mindful of that.
I mean, I don't think it helps with some of the language, but some of the concepts people are discussing are in the definitions of medically appropriate, medically necessary. I think it helps probably just look at them. They're pretty specific. They do cover a lot of the situations that people were just discussing, and you can kind of get caught up because medically appropriate, medically necessary is used in different ways in a lot of different contexts. But how I look at it is say, what component of it does it meet? And then yes, it falls under that general definition, but a lot of those concepts people are worried about is covered in those definitions we use. So
But I feel like keeping the appropriate term around a little bit more than has been thrown around, I think, so far today is really important. It's not just medically necessary, but also or appropriate. And I think appropriate is a term that does expand our ability to bring in values and preferences. So maybe if it's medically necessary / appropriate, or medically necessary or appropriate. So I think that makes a lot more sense. I think that's the intent. I mean,
they both require each other, so I say both always.
Right,
because
I agree.
one precludes the other. But I think it would be helpful maybe to like review the definitions before each meeting, because there are a lot of subsections to it. Like I use them all the time. I don't think anybody else has maybe even read the entirety of them, because why would you? We don't come across it. But I think that's helpful to kind of orient people on what
Yeah, well, I hear what Linnea is saying though, that we can review it before each meeting, and the fact that this body of experts, many of whom work in the industry, needs to review it. You know, the general public is gonna read something different into it, and so how do we bridge that gap? And I think that's something I'll take back to discuss as we prefer communications with the public.
I mean,
it's a really good point.
You could too, I mean, I don't know if we do this, but so when we have to do rulings, when I use those definitions, I have to cite each subsection that I use.
Sure.
So I say it like goes directly to this. I don't know if that's useful, but you can say when
Well,
we
it's useful
review
for legal
topics-
purposes, but for.
Well, I mean, like when we review topics, because we're not just saying it's medically necessary and that can be read different way, we can say, hey, it fits under this
Oh, I see.
idea or this concept that's required of that definition. This is the one we actually operationalize. I don't know if that's helpful or not, but it gives a lot more insight and kind
I
of
can think about that,
directly
yeah.
goes to that. At least internally, it's helpful because I mean, that's how I look at them, right? Does it meet all these criteria? If it doesn't, or if it does, and that might help some people kind of grasp what those concepts and those words.
Even though you're saying the decision we make today might be the same as the one we make 2 years from now, we might use different language in the rationale that ties more closely to the rule.
Yep, and it might be a little more transparent
What do you
on
think
why
about
we're
that,
calling it
Ariel?
medically necessary.
I don't think that we can do that.
I'm not sure we can do that completely.
No, I don't think we have to. I'm just kind of idea, and that kind of adds a transparency to that. Because at least in the discussions, that's how I'm gonna refer to things. Like, hey, well, this definition is there. I think it fits this or not.
And then there's another layer that's pragmatic, like talking to the allergist about allergic rhinitis, and that's gonna be a big change. They're like, well, people only actually come in for weekly allergy shots if they're miserable.
Right.
So, there's a pragmatic layer.
Absolutely.
But that.
And that's where I think of the term appropriate, is a great term to describe that situation. Like, advanced treatments for allergic rhinitis are medically appropriate when the symptoms are bad.
Any final comments, staff, commissioners? I know we've chewed on this a lot today. I don't want to end good discussion.
And I just want to reiterate to everybody that we're building this airplane as we're flying it. So you might see a proposal coming in January, and then the March proposals might look a little different because we'll learn. So just be flexible. The other thing I wanted to let the folks who joined for HERC know, what staff are planning on doing are publishing in our packet a lot more of the BUP issues than we actually are planning on talking about at a meeting, so that they're out in the public, they're out for people to give us comments on. So don't panic if you see an agenda for January. I'll probably on the agenda put the ones I think we're gonna talk about, but if your packet comes out and it has 10 different specialties, don't panic.
When you say packet, you mean materials?
The meeting
I'm sorry,
materials.
materials,
We
yeah.
may even just publish a separate document that
That
says
actually
these are
probably be
things coming to
helpful.
a future meeting, but posted for comment now.
And
because
your
we're-
intent to do that is to just enhance opportunities for transparency.
We're getting a lot of, as this is getting out into the world, specialties and CCOs are being really anxious about certain things. So I think seeing things in black and white that they can respond to
Do we know
will
what the
lower the
anxieties,
temperature.
where the anxieties lie, like they're worried about coverage decreasing, or they're worried that they want to have a chance to express their particular concerns, or is there
A
quality or a-
range of things, you know.
And this is just about the benefits update, the benefits update project in general is bringing these concerns to the forefront.
Yeah, it's an opportunity where the duck's being reshuffled. And so it's an attempt, it's a place, if you've got a longstanding grievance with something that's below the line, this is a great time to talk about it. And it's an appropriate time to talk about it. It's
The
just-
allergist actually organized to come and talk to us about allergic rhinitis, and I was like, okay, I can start this meeting by saying yes, and then now I'm gonna rope you in to talk about a whole bunch of other stuff. So.
Yeah, no, it's exciting, it's just, overwhelming perhaps.
And I'll just comment, I think it's a good idea to start putting things in front of people, because even maybe because I'm not as in the weeds as some of the other people are, this is taking me multiple times to look at this and try to process this and see this from a different lens, to then try to see how this is going to be rolling out. So I
And
think
also to the comments that were raised today, as much as this is gonna be accessible to patients or at least patient advocates, it'll be out in the world for them to respond to as well.
more to come unless there are any final comments or questions. I don't think any motions were necessary.
No, that was all information.
Nope, that was just informational, but again, if you think of additional things, email us early and often, it will do more good that way. And our next meeting is January 16th, 2025, believe it or not, same place, same format.
Is there anyone who already knows that they're going to be absent so that staff can start working on quorum?
What day, January what?
16th, Thursday, January 16th.
I tentatively might not be here. I'll have to double check my calendar. But I'll let you know way ahead of time.
Thank you.
Anyone else? Or any final
All right.
comments or questions?
Thank you all.
This is Chris. Thank you everyone for good discussion. I gotta take off.
Adjourn.
Hit the gavel.
Thank you.
Bye, everyone. Okay, we are adjourned.